છે યાર.
ની બાર છોકરીઓ હું એકલી જ છું. ના બીજા બધા મેમ ના આઈ ગયા હેડ બધા. છૂટા
શું બોલું?
ના વોઇસ કરું એટલે આવશે.
I request all the delegates to mute your speaker. I request all the delegates to mute your microphone.
Under system નો જે વોલ્યુમ હોય ને એ પણ આવે છે.
So now we are going to start with the conference. Life is a miracle and every breath we take is a gift. With this beautiful line, I, Sachi Christian, Assistant Professor, Dinsha Patel College of Nursing, welcomes you all in this National Conference on Advancement in Critical Care Nursing, organized by IQSC and Department of Medical Surgical Nursing, DPCN. A very good morning to all the dignitaries, faculties, and dear students. Now, let us have the pleasure of listening welcoming remark of our Vice Principal of DPCN and organizing member of today's conference, Mrs. Arpita Vaidya ma'am. Over to you, ma'am.
Thank you, Ms. Sachi. Good morning and Jai Maharaj. I, on behalf of Dinsha Patel College of Nursing, it is my great pleasure and honor to extend a warm welcome to all of you in the virtual national conference on the topic of the advancement in critical care organized by Internal Quality Assurance Cell and Medical Surgical Nursing Department, Dinsha Patel College of Nursing. I warmly welcome Dr. B.A. Shelat sir, Director of Dinsha Patel College of Nursing. We feel really enthusiased by your presence, sir, among all of us. I welcome you, sir. I warmly welcome today's resource person of virtual national conference, Mr. Nipin Kalal, sir, Assistant Professor, College of Nursing, Assistant Nursing Superintendent and Transplant Coordinator, All India Institute of Medical Science, Jodhpur. I welcome you, sir. I welcome Mr. Divya Jain, sir, Assistant Professor, Manikaka Tupawala Institute of Nursing, Charuset. I welcome you, sir, in today's session and in conference. I welcome Professor Virendra Kumar Jain, sir, Principal Dinsha Patel College of Nursing, who have been actively associated in planning of this conference, in the initiation of this conference, and your kind presence, sir. I welcome you, sir, in this conference. I warmly welcome organizing secretary, organizing member of Medical Surgical Nursing Department, Dinsha Patel College of Nursing. I also welcome delegates, participants, students, and the faculties of various nursing institute. Once again, I welcome all of you in this virtual national conference. Thank you. Over to you, Ms. Sachi.
Thank you, ma'am, for your warm welcoming message. I request all the delegates, if you have any queries or doubts related to expert session, you can write in the chat box. Critical care nursing is a field of nursing with a focus on the utmost care of the critically ill or unstable patients following extensive injuries, surgery, or life-threatening disease. Critical care nurse can be found working in wide variety of environments and specialties. To enhance our knowledge in this topic, we are glad to have an eminent personality with us in nursing profession, Mr. Nipin Kalal, Assistant Professor, College of Nursing, Assistant Nursing Superintendent and Transplant Coordinator, All India Institute of Medical Sciences, Jodhpur, who will give his expert knowledge on the topic of challenges and management in critical care. Now, it is my privilege to introduce his journey in the nursing profession. Sir has done his graduation from Bharatiya Vidyapit University, Pune, and post-graduation in medical surgical nursing from Sumandip Vidyapit University, Baroda. Sir has attended training and orientation of organ and tissue transplant organization from PGI Chandigarh and SGPGI Lucknow. Sir has done certified course of transplant coordinator from National Organ and Tissue Transplant Organization at Delhi. Sir is a life member of Indian Association of Transplant Coordinator and TNAI. Sir has received University Gold Medal for securing first rank in MSc Nursing, award Best Paper Certificate by International Journal of Nursing Education, New Delhi. Sir has published and presented various papers. Sir is examiner in various universities. He has organized workshops and conferences. Sir is recruitment panel member of various institutes. Sir has invited as a resource person in various conferences. We are very honored with your presence, sir. Now, I request sir for an expert talk.
Very warm good morning. First of all, I would like to congratulate and thanks to the Professor Virendra Jain sir, Principal, Dinsha Patel College of Nursing, the organizing secretary, as well as the organizing team member, and all the supporting hands behind this event. The topic which is chosen for today's conference, that is the advancement in critical care nursing, is a very important aspect. This component has been highlighted by the government of India, especially we have seen in COVID pandemic. So I personally thanks to Professor Virendra Jain sir and entire team for inviting me to deliver the session on the topic challenges and management in critical care. So just give me a second, I'll share my slide. Is it visible? My slides, you can see it?
Yes, sir.
Yes, sir.
Okay. And I hope I'm audible too.
Yes, sir.
Yes, perfect. Okay, so the topic which is given to me, that is the challenges and management in critical care. It's a very broad term. If I talk about the challenges, this aspect cover many more things, and as well as the management part, because each individual have different aspect in term of management. So let's see how we can accept the challenges, what kind of challenges we have usually face in critical care unit, and how we have to deal with this. In terms of challenges, I'll talk about the basic challenges, and once I'll move toward the management, I'll talk a little bit about the patient management. So today in my topic, I'm going to discuss about the meaning of critical care unit and what is the critical care, meaning of challenges in critical care, challenges in critical care, overcome with the challenges, how we can overcome, what technique we have to use, and what kind of management we need to deal when we have certain challenges. Meaning of management, management of critically ill patient, how we are going to manage the patient, for those who are critically ill and admitted in critical care. So these are all the topics which I am going to cover today. First, we will see what is a critical care unit. As a critical care unit is a specialized section of the hospital that provide comprehensive and continuous care for the people who are critically ill and who can take benefit from it. So these are the very important part of the hospital where the very ill patients get admitted, and obviously they are going to get benefit from the treatment. So that such kind of unit is required, and we can see the heart of the hospital where many more critically ill patients get admitted. What is the critical care nursing? Always we are talking about the nursing aspect. So it's a field of nursing with a focus on the utmost care of the critically ill or unstable patient. And who are the critically ill? This is the three triangle actually. When we are talking about the critical care, this is a critical care unit, critical care nursing, and critical patient. So critically ill patient, this is a critically ill patient, those who are very sick, actual or potential life-threatening health problem. Those who are really going through the illness, having the life-threatening situation, they are really need a care, except we can say the quality of care required. What do you mean by challenges, or what kind of challenges we are facing? The challenges is something new and difficult with required great efforts and determination. So whenever we are working and when we are talking about the critical care, always we are facing some kind of challenges. So in any of the challenges, this is generalized in terms of generalized I'm talking, we are facing any kind of challenges. So what we have to identify the problem, what we are facing through, and what we can do that. Once we are facing any problem, we have to define the problem. And once we'll define, we'll come to know the actual problem. Once we'll get the idea about the problem, then our brain will work on that. Brainstorming will be there, and we'll get an idea, we'll get a solution actually, what we have to do that. And certain solution we have to list down, and we have to see the priority, which solution will have more effective in that certain kind of challenges or situation. We have to pick up the solution, we have to implement it, and we have to see the result. If we are not getting proper result, then we are always look after for the revision, we have to always look for the review. Then we'll come to know where exactly problem we have to face, we have faced it, and what kind of solution we actually require. If we see the certain paper has been published and the challenges and work crisis which is faced by the critical care nurses. This is one of the articles which is published by GIP Nursing Journal, and they have seen and they have find out the result. The workload is very high in the critical care unit. This is one of the biggest challenge I can say that. Inadequate time to complete the work assigned to him, need to work for a long hour, or we can say it's a long shifting duties, large number of the patient at the ICUs, and increased number of the night shifting. So these are the basic findings of one of the journal, and they have seen that these are the basic component or basic challenges what the nurses are facing in critical care units. This is one more article that's showing that the challenges encountered by a critical care unit manager in the large intensive care unit. Okay, in terms of the, we can say in charges what they have seen, and they have used the qualitative, explorative, descriptive study, and they have taken this data and they conclude that the ICU manager, they are facing, there is a demand, there is a supply, there is a special kind of the nurses, the inadequate of the equipment, the supply which are getting inadequately in the ICU, and overall the planning and control of the daily activity. Such kind of the problem they have faced. So the article which has showing that these are the common phenomenal problems which is faced by the critical care unit, critical care nursing, or the personnel or the professionals are working in the critical care unit. Now I'll talk about the challenges which is usually faced by the institution. There is a separate, we can say, the component for the institutional, what they are facing the problem or challenges, what the healthcare personnel, what the patient, because it's a comprehensive way, not only the one aspect or the component which are facing the challenges. So we'll see what kind of challenges is faced by the institutional. The first, that is unavailability of the proper infrastructure or limited ICU bed. As we have seen during the pandemic, there's a critically crisis of the ICU bed. They were not having the ICU bed, they were not having the oxygen bed. So we do not have much infrastructure in Indian scenario or Indian setup. So this is one of the challenges which is faced by the institution. It's not only in the government sector as well as in the private sector. They are facing these challenges. And limitation of the ICU bed, this is the core area of any institution, where we know we have the emergency department from where we will get the critical patient. from the IPD, even own IPD, where the patients get deteriorated, they might be shifting to the critical care unit. The third area where the OT, after the post-operative, they have to shift it to the critical care area. If so, we have limited ICU, then we cannot, cope up with this situation, and we face this problem. So, the limited ICU bed is one of the challenging tasks or challenging from the institutional end. Second one, the shortage of life-saving equipments. Even though if we can arrange the bed, but if you do not have life-saving equipment, especially if I talk about the drugs, if I talk about the ventilators, if I talk about the monitoring, if I talk about defibrillator, these are all the life-saving equipment which are required. If it does not have, even though we are having the bed, then we cannot manage the patient. So that's why whenever we are talking about the ICU, we always say that ideally the bed strength of the ICU is, we can say 6 to 12 bedded ICU, ideally. Okay, or maximum we can go beyond like 20 bed ICU. So that's not up to the mark even, because we require more ICU bedded and we require more equipment also. If we have 12 bedded of ICU and we do not have equipment, like we do not have mechanical ventilator, then it's not useful. So there are life-saving equipments are very short. That's the institutions are facing that problem. Policies and standards, very important part. Because in Indian scenario, we know somehow there is a, the influences will be there for the admission, for the discharge, for the financial problem, and many more. So if we do not have any kind of policy, we always have the admission policy. Because many of the tertiary care center, they know what kind of the patient they have to admit it. The patient which really require the care and who can become, cure once we're giving the treatment. So that's policy should be there. So it is very important to have admission policy, very important to have procedure policies and standard of the care in the institution. If it does not have, then the patient will remain inside the ICU for a longer days or more than the required days. For an example, just I'll tell you, if suppose the one patient got admitted in the hospital and he had some of the critical illness. Suppose patient is on ventilator, and if you do not provide the proper care, then what will happen? He might get, ventilator associated pneumonia. Then again, he will remain in the ICU for the longer days. Suppose he might be there for the 5 to 8 days, and he has to suppose be there for 20 to 20 days. Then again, the quality of standard has been reduced, the care has been reduced. So what will happen? He will remain for the longer duration, and the patient, those who are waiting outside who require the ICU, he may not get the bed. Financial burden, obviously, if you do not, if you require more ICU bedded, if you require more equipments, then we should have more and more financial. So very difficult to manage with all the requirement in the private institute, even the government also, because the budget what we are getting in the health sector is not much compared to the the abroad country. We are getting very high impact of the budget for the financial for the health sector, but what we are getting is very less. So this is also one of the problem. Increase number of the patient admission, because as we know, the non-communicable diseases are very high in the number. Even the road traffic accidents are very high. So people are getting, require ICU admission, but they are not enough. There are not enough ICUs are there, not enough critical care units are there, which are admitting such kind of patients. Aging population and increased life expectancy. If we go little earlier, the life expectancy or increase expectancy of the life age was 60 years of age, but now the WHO is saying the age expectancy is increasing now up to 70 years to 72. So aging population is increasing, and once the aging population is increasing, they might require more care. They might require more number of critical care units for them. Unprecedented pandemic, which we have observed, like COVID, we know that if such things are happening, then we need to have more institution, we need to have more ICU bed, then only we can take care of them. Otherwise, we have gone through the second unsurged COVID crisis, and we have observed that many of the patients are died just because of not getting the ICU bed, just because not getting the oxygen therapies. Lacking in healthcare innovation, because if I compare to the foreign countries and the hospitals, they are very advanced in healthcare innovation. Now we are just going through little bit. Now we have started the telehealth services or telenursing or telemedicine services, but they were doing very, since before only. So now we are going, and we do not now focusing on artificial intelligence. We are very, you can say, in infancy age of health sector in the artificial intelligence, because Artificial intelligence is the system where the machine itself recognize what kind of the problem patient is facing and what he or she can do that. So healthcare innovation is very important part where we can stop such. So the healthcare innovation is required. This is a very important part. Is then so these all are the basic challenges which is faced by the institution. Now I'll talk about the challenges which is faced by the patient. What the patient we are facing challenges that. The first one, this is the patient's and family expectation. That's very important. I request all the participants, please mute your mic. So at least we will not have disturbance. It will help flowing the presentation. So challenges of the patient, what they are facing in the institution, that the patient and family expectation. Their expectation of the family and patient is very high. They want quality of the care. They want completely, they want to cure from the any kind of diseases. So they are having much more expectation. So that is also one of the challenges to fulfill their demand, to make them assure that they will recover, they will get quality of care, and we have to reinforce that. Because until and unless patient and family satisfaction will be there, we are not doing well. So it is very important part of one of the major challenges we can see. Avoid monitoring. That's things happening because of the large number of the patient, small number of the health personnel or the staffing, or we can say we do not have much more monitoring monitor system to make them monitor. So that's what is the problem. Isolation. As we know, the patient will become isolated, feeling of isolation. That is also one of the patient, because we cannot allow patient related to be with the patient or always remain, because this is also again the causing the infection. So isolation is one of the patient challenging for the patient. ICU psychosis. We have seen many of the patients, those who are getting admission in the ICU, and they are facing these challenges. And that's why now, if you have seen the new setup of the ICU, they have entire change. Previously, if you have seen, there was a closed unit of the ICU. There is a thickened wall will be there. We cannot see anything. But nowadays, they are using the transparent mirror or the transparent glasses actually. So easily they can see the outside environment. Patient, if in ICU, they cannot come to know whether it is morning time, evening time. They will change their circadian rhythm also, and they will develop these problems, ICU psychosis. So now the setup has been changed, and just we are minimizing this problem. Length of the stay, because when the patient get admitted in the ICU, so this is one of the biggest problem. If we remain for the 4 to 5 days, if the quality of care will not be there, then the duration may get increased or it will be having longer duration. So that is also one of the challenge for the patient. Lack of orientation and mentoring, very important part. Because sometimes we all diverted toward the patient care, but we are not directed toward the family behavior. It's not going to orient them about, we are not going to mentoring them. We have left behind the psychological support. So we should have the psychologist apart from the physician or nursing staff who always give support them. He'll talk to them what exactly problem the patient is facing, what kind of the management is going on, and what else we can do for the patients as well as a relative. Then visiting policy should be there, because sometimes the patients are relative. Once they are not able to meet the patient, they always ask for the visiting the patient again and again. So we have to explain, or there should be a visiting policy which will clearly define them what time they should meet to the patient. So these are some of the few of the basic challenges which is faced by the patient. Third challenge is what the healthcare professionals are facing in the critical care. Practicing beyond the scope of practice. If we have job description of individual. We know what nurse has to do. We know the head nurse what they have to do. We know the person, those who like medical team, what they have to do. But sometimes we are going beyond to that because of untrained staff, or we can say the less number of the staff. They are doing the extra work, and this extra work may causing the burden on the healthcare personnel or healthcare professional. So this is also one of the challenges. Shortage of skills specialists. Here we require the skill, because ICU and critical care unit are entirely different from the routine IPD ward, or we can say what are the patients those who are coming day by day in routine OPDs also. So here the person, those who are working, they should be very skillful. They should know how to work. So We need a skilled specialist, a person, those who can take care of the patient. So in the health scenario, we know that the shortage of the skilled specialists are there. And currently, almost more than 12 millions of the nursing staff required globally, more than 12 million. And if I'll be, you will be surprised to know that only the two countries which are producing the nurses, one the India and one the Philippines country. The two only the country which are producing the nurses, but we are not much enough to occupy all the requirement or fulfill all the requirements. So there's a shortage of skill specialists will be there. Problem of working as a team. Because if we are working in the critical unit, we should have the teamwork. There will be always there is a problem or there is a miscommunication or we can say the mismanagement will lead for the certain kind of the conflict. And if we do not work as a team, then this will become a problem for the entire unit, for the patient, for the critical care unit. So this is also one of the problems. Error in practice. Now, error in practice, if we have, many of the studies are suggesting that we are doing many error in clinical practice. The reason is that why there's a shortage of staff, much more workload, and this are going to lead for the error. And this error are one of the challenges for healthcare professionals because if they do error, this again they are getting such kind of the harsh punishment, or they might be this is one we can say part of the ethic against the ethical call. So this is also one of the problems. Inadequate intensive trained staff. As I told you earlier only, they require some kind of the staff which are trained because in the critical care when you are working, you know the ventilator, how to operate them, you know the defect, how to use it. There are many more monitoring system will be there. So they should be very skillful. They should be very thorough with the all the kind of the the technical things will be there in the critical care unit. Recognition, autonomy, and support issue. This is also one of the major component area of the healthcare professional which they are facing day by day. Because if they do not have identity, they do not have autonomy, then they cannot work properly. So there should be recognition should be there. They should be award, they should get award and reward day by day. So they will have positive enthusiasm toward the work. And support issue, they should get support from the hierarchy, all the team. So it will become the good. But if they will not get this, then this will become challenge to them. Workload does a long duty hours. As you know, wherever the shortage of the staff will be there, they are doing the double duty, they are doing the triple duty, they are taking hardly few times a day. So this phenomena will not work in critical care unit because you should have good strength, good endurance when you are working in the critical care unit. Then only you are working, you can work for a longer duty. And if there is a study suggesting that if you are doing the long duties, then obviously this burden will be there and the quality of work will be decreasing. So these are the basic challenges which will be faced by the healthcare professional in the critical care unit. Now, these future challenges in the critical care unit, what like we require the more ICU, we require certain kind of the expanding the ICU bed capacity, better end of life care. We need to have proper supply the consumable devices. We have safer ICU design, more focus on well-being of the ICU staff also because they are human beings. They also require rest. They also require the kind of the dignity. So we have to always think about the ICU staff also. The restructuring or multidisciplinary route. We should have multiple team which will has to work toward the patient's care. And this is a comprehensive team has to work toward the patient care. Digital transformation, as I talk about the telehealth services and artificial intelligence, we have to work toward that. So these are the major challenges which has to be, we are facing by the critical care unit, and they have to, look to that. Now, how we can overcome through these challenges? What we have to do? So this is one of the critical care design actually. So we have to focus on this component. Through that, you can overcome through these challenges. First one, that is the open ICU visiting policy. The policy should be there for the visiting. So once you have policy, you can overcome with the challenges. That's what the patient's relative they are facing. Communication, very important part here. Communication with the patient, communication with the family, communication with the senior hierarchy member, physician, or any of the person, those who are involved in the care. So it should be a very good part. If you have humble communication, you can sort out any of the problem. Next, there is the well-being of the patient. Is a very important part because this is the core component or the core area where we have to focus. We have to always keep in mind the patient care is always priority, and we have to always think the well-being of the patient. Presence and participation of relative in the ICU, because to avoid the things which is to avoid the as I told delirium or the patient psychosis, we have to always involve the relatives in the care. So they will also get competent. Patient will become enough mingle with them, and it will help for the recovery also. Even many of the studies also suggesting that we have that tactile phenomena or tactile care, we have auditory care, which are involving patients relating, and it will have impact on good. There is outcome of the clinical outcome. So we have to involve the patients relative in the care. Caring for the healthcare professional also, because there is only not we have to think about the patients only. We have to think about the professionals also. We have to take care of them also. So they should get proper rest. That long duty should be, it should be not in the term where they have to go for the longer hours only. So always we have to think about the professionals, those who are involved in the critical care unit. Prevention, management, and monitoring of the post-ICU syndrome. This has very important part, and already I talked about that. They humanize the architecture and infrastructure will be required for the critical care unit, and if structure is proper, is expanded, it is the open unit, then the quality of care can be rendered best and be very good and effective and end of the life care. Because it is not necessary every care will have positive outcome. Sometimes the patient, those who are admitted in the critical care unit, maybe we cannot be recovered, but the end of the life care can be improved. We can reduce his pain, we can reduce his symptom, and we can provide on the quality of care. So such kind of this design we have to keep in mind whenever we have to overcome the certain challenges, what the institutional base, patient base, healthcare professional base, and how we can improve the quality of care. The organization characteristics facilitator of the critical care, which are the basic required. This is one of the actual model actually, where we require the strong leadership. If we do not have strong leadership, they will not follow the order. They will not, quality of care cannot be rendered. We should have intensivist staffing. Intensivist staffing means all the person, those who are working in critical care should be well trained and they should follow all the basic procedure with aseptic techniques. We should have ICU registered nurse patient ratio. It should be, it's usually 1:1. It should never be beyond 1:2. Daily ICU team rounds actually. They should take around daily visits. They should see what they can do because the comprehensive round will have more effective. Because once the patient got admitted in the hospital or critical care unit, he may require the round from the hospital supervision, from the nursing side, from the medical team side, maybe from the physiotherapist side, from the dietitian. So comprehensive care will be required. Bundle of checklist and call sheet. We know that when the person is admitted in the critical care unit, they have bundles of care. Like we have to prevent the OT, we have to prevent the SSI, the clepsy, and ventilator associated VAP also. So this we have to know how we have to take care of them. CQI, that is the continued quality improvement. CHR, that is electronic health record that has to be measured on a regular basis. Collaborative work environment should be there. Safety culture should be there because if we know the NABH instruction, we know that when they are always talking about the safety culture, patient fall, and this is very incident reporting should be there. So we have to create a safety culture for the patient, for the healthcare professional, because we know the many times in the hurry we can have injure ourselves, or staff are getting injured ourselves, like they are having needle stick injuries also. So we should have create the safety culture environment. So these are the phenomena, and what the ABCD bundle facilitators that that's assist, prevent, and manage pain. The pain management in ICU, that's very important. Both spontaneous awake trial and spontaneous breathing trial, when the patient will be on the ICU and ventilator, they are doing this trial by giving decreasing the sedatives. They can go for the spontaneous awake trial, and they can decreasing the assisting device like ventilator, and they can do for breathing trial. So this is one of the clinically important component which has to be taken care of. Choice of analgesia, sedation, this is the medical management, what they have to see. Assist and prevent manage the delirium, that is the ICU psychosis. Early mobility and exercises will provide the better recovery, and family engagement and empowerment, because family should be engaged in the care and they should be empowered where to take a decision and what kind of the care they are getting. So this is the facilitators of the critical care which has to be focused on. There are certain models of the patient care center, which are always we have to focus on patient care centers because this is the core area. So here, mission and value aligned with patient score. Because previously when I talked that we have always worked toward the patient's care. Care is collaborative, coordinated, and accessible. Because without collaboration, we cannot, do the betterment of the patient. Or one department only cannot run the critical care unit. We should have the multiple department. We should have collaboration. We have comprehensive units that can provide better and better care. Physical comfort and emotional well-being are the top priorities. Patient family viewpoints respect their values. Patient family always included in the decision. Family welcome in care setting and full transparency in fast delivery of the information. So this is one of the model which will always focusing on the patient care. And similarly, one more model is there, which is also focusing on that like physical comfort. We have to see the physical comfort of the patient. We have to respect the patient value, integration of the care. That's all the departments should come together for the care of the patient. Patient empowerment. Patient should be empowered to take the decision, what kind of the care he is getting, and what is his or her expectation. Emotional support is very important part because stress is a major component in the ICU or especially with the patient. Involvement of the family in the care, access to care. He should get all the kind of the care which he deserves. So it has to be, in the priority and continuity of the care. It should not get stopped. If it is from the critical care, then when we shift it to the next unit or the transition of the care is also very important. So there is a readmission will not be there, deterioration will not be there, and he'll get the point of care. Now I'll talk about the management of critical care, how we can manage that. Till now we have seen what challenges we are facing, how we can overcome with the challenges, and now I am talking about the management in critical care. Any kind of the management we should have four major component. Organizing team should be there. We should have enough coordination with the team. We should have leading person who can managing and motivating the people, like how we can, we have head nurse or the senior nursing officer, the nursing officers, and controlling, monitoring, and evaluating activity should be there, and planning and decision making, determine the course of the action, what we are doing. We should have the evidence-based science for that. So this is the how we can manage it, or what component we have to keep in the mind. Now, if I'm talking about the management, then we should have resources. Currently, we cannot manage anything without the resources. One person cannot do anything. Like immediate availability of a surgeon, physician, anesthesiologist, nursing team, emergency room, OT, ICU, radiology, laboratory, blood bank, and 24/7 facility should be there. Because if we have critical care unit, then all the person or all the department should be there. Otherwise, we cannot provide the complete care. If any of the things which is not available in our hospital or in critical care unit, we cannot go for that. So that's why this model is giving clear idea. If we have the critical care area, then it should be within the facilities of operation theater, emergency care, radiology, and inpatient acute services. This color coding, you can easily understood that this is the red color which is providing or it should be easily accessible, so that operation theater should be near to the critical care area. Inpatient acute services, emergency care, and radiology, it should be within the accessible. So easily when the patient is getting anything, immediately he can shift it to the OT. If he get deteriorated and he requires critical care, immediately he can shift it to the critical care unit. So, and other services like infection control, pathology, pharmacies, or sterile supply, it all should be within the same building. So these all resources are required to run critical care unit. Otherwise, we cannot run our critical care unit if any of the things are missing in our department or in our unit. So this all component require that. Equipments. If we want to manage the things, then we should have equipment like airway equipments like intratracheal tube, oropharyngeal, nasopharyngeal, tracheostomy, EMBO, mechanical ventilator, anesthesia machine, monitoring device, infusion pump, warmer device, emergency and essential drug, defibrillator, and many more equipment like in this. We have seen the all the setup which is required for the critical care unit. We should have enough spacing. We should have storage area. We should have linen area. We should have pantry, the patient visitor room. So all these resources or all this equipment are required to run the critical care unit. Now, management begins with receiving a sick patient in the ICU. It's always, it is not that like the patient already inside the critical care unit and our management will start. No. Let's begin with once you are getting called for the receiving of the patient area, your work will start in the critical care unit. We have like other point we'll cover slowly that rapid cardiopulmonary assessment, drugs, that dose, oxygen therapy, care of endotracheal tube, central line, college and other drainage tube, general nursing care in the ICU, nutrition in the sick child, maintaining aseptic and transfer of the ill patient. So this all until you receive the patient and you transfer the patient. That's critical care area work will begins with that and with the transferring the patient. Now receiving a sick patient in the ICU, whenever you're getting called that one of the patient is coming to your critical care unit, you should have certain prerequisites. Like you should have adequate information about the patient's status. You should know if the patient is shifting to the ICU, why he is shifting to the ICU. What is the status of the patient actually? What the vitals parameter he has, what kind of the care he required. We have to prepare the bed. Whether he required any special hydraulic bed, he required which kind of position. So we have to prepare the bed. Arranging the bedside tray. We have to arrange all the bedside tray. We have to arrange assessment tray. We have to arrange the tracheostomy tray, intubation tray, because patient when shifting to the ICU, what kind of care he require exactly. Oxygen therapy, whether it is functioning or not, proper supply is there or not. We have to see whether monitor, we have to attach all the cable line, we have to start the monitor. Infusion, we have to keep ready, whether he required what kind of medicine, whether he required the inotropes, whether he required the routine fluid therapy. So we have to keep all the infusion ready, suction apparatus, whether it is working or not, the pressure which is required for suction apparatus is there or not. So before receiving the patient, you have to keep all the things ready. Then you can say, yeah, you are ready to receive the patient now. And whenever you are receiving the patient, there is a contained which is isobar that you have to follow. You have to identify the patient in 3 terms, 3-way, and all the information you have to gather. You have to see the situation, like from where he is coming, what kind of the unexpected event is happened, and why he is coming to the ICU. You have to observe for the vital sign. You see the background, all the past history, allergy, sensitivity, assessment like patient progresses and status of the patient, and recommendation what need to be done, when and by whom. So this isobar technique you have to use whenever the patient is coming. You have to follow that, identify situation, observation, background, assessment, and recommendation, and you have to follow that. After receiving the patient, rapid assessment of the physiological status of the client should be made, followed by the recording of vital sign. This is the rapid assessment. You might have seen that airway, breathing, circulation, dysentery, exposure. Anytime it can be happen. Anytime you have to ready for that. Either it is the suppose patient is getting anywhere coming to the ICU, from the OT table to the ICU, from the IPD to the ICU or critical care unit. Always you have to look for the airway management, breathing management, circulation, disability or exposure. You have to do it. And rapid assessment you have to do once patient will reach to the critical care unit. You always have to see for the CNS function assessment. Like you have to go for the level of consciousness with help Glasgow Coma scale. You have to see for the integrity of the brainstem, whether patient's brainstem is working or not. There are certain tests like cold calorie test, apnea test, which will be done for the patients of the brainstem. You have to see for the sign for the raised or intracranial pressure and any kind of the seizure activity. Then you have to go for the CNS function assessment, and you have to see whether what kind of the deterioration will be there. Now, if we find any problem, then what we have to do? If there is a problem in the airway, then we have to opening the airway. We can go for the endotracheal intubation. If patient requires the respiratory support, then we can go for the oxygenation or bag ventilation. If we require the circulatory support, then we can go for the vascular access, intravenous or intraosseous therapy. We have to do the expansion of the volumes, or we need to give some resective drug therapy also. For the CNS protection, we have to control the seizure, control the intracranial pressure, and finally, we have to correct the metabolic impairment. So, on the basis of the finding, on the basis of the rapid assessment, we have to stabilize the patient by doing certain measurement. Many of the emergency drugs which will be used in the critical care unit, like IV infusions, like RI, NS, mannitol, Storabecca, KCL. Circulatory support will be like we are using some of the inotropes drug like adrenaline, atropine, dopamine, noradrenaline, dobutamine. Anticonvulsant drug like diazepam, midazolam, phenytoin, phenobarbital, antiarrhythmic like amiodarone, procainamide, And other drugs like insulin therapy, maybe heparin, sometimes morphine, naloxone, and certain antidote also required. So these all are the emergency drugs should be there in the critical care unit and should be always will be in the monitoring and daily this, we should have proper indent. We have done the daily checking of this medication for the expiry, whether it is available or not, and it should be done on the daily basis. We should keep oxygen therapy in case of the respiratory distress, shock, poisoning, asphyxia, and then the variety of the modes which will be used for delivering of the oxygen therapy like nasal prong, simple face mask, partial repeater mask, non-repeater mask, phase 10, tracheostomy, venturi mask, endotracheal tube, and many other modes will be using for oxygen delivery. The person who is in the critical care unit, the patient, will have several lines, tubes, catheters. He might have an endotracheal tube, tracheostomy tube, urinary catheter, drainage tube, central venous line, nasogastric tube, intravenous line, suction catheter. We have to take care of all the tubes because endotracheal tube, we should know when to clean. If there is any kind of discharge is there, we have to do the dressing. Tracheostomy tube, we have to go for the dressing. We have to see the patient cannot self-remove that. You have to see for urinary catheter also. Proper cleaning should be done. It should be changed on the time. If any infectious is there, we have to see for the urinary color also. Drainage tube, we have to monitor how much drainage is coming, the amount of drainage is coming, the color of the drainage is, and proper dressing we have to do it. Central venous line also we have to see for that whether it is blocked or not, heparin is used or not, what kind of the fluid you are giving, daily dressings you are doing. Nasogastric tube, the daily we have to do the aspiration, the amount of the feed what you are getting and what you are giving. Intravenous line we have to see whether there is any inflammation or cavities is there or not, or how frequently we have to change the cannula also, and suction catheter also we have to change frequently. So these are all the tubings will be there in the patient with those who are admitted in the critical care unit. And we have to take care of all the tubings which will be there. And we know that nowadays we have advancement of the dressing material. Nowadays you might have the tegaderms, which is already a transparent dressing, and it will have solution which will be functioning as antibacterial. So the chances of infection will be decreasing day by day. So many advancement has come in terms of the dressing, and it will reduce the infection rate also. Now, management of critical care ill patient in terms of the broadly I'm talking about here, because each system will have different care in critical care unit. So we should have complete monitoring. We should have vital sign monitoring. We should have psychological aspect of the monitoring. We should have physical aspect of the monitoring. In all the term, we should do the complete monitoring of the patient. Second, respiratory care is very important. Patient may have breathlessness. So what we are doing here, we have to give the ventilatory support. We have to give the oxygen therapy support to the patient. Postural drainage will be there. We have to give positioning also. We have to give chest physiotherapy. We have to teach them about the diaphragmatic breathing exercises. That will component of the respiratory care will be there, as well as other component also will be involved in respiratory in terms of the spirotherapy. Cardiovascular care, we should take care of the heart. As intervention will be specialized intervention will be required. We know after this, especially angiography, angioplasty, even after the surgery like the wall replacement therapy or the CABG, they require the special attention and special care after the cardiovascular diseases. Gastrointestinal and nutritional care. We know my patient may have colostomy, so how we have to take care of the colostomy, dressing, how we have to change the colostomy bag, and what kind of fluid we have to provide, because patient itself cannot take the fluid. So fluid should have each component, and we have to refer for the dietitian so we can provide proper nutrition to the client. Neuromuscular care, patient with the age, they require some neurological care, some muscular care, and all the reflexes has to be checked and provide proper care to the patient. Comfort and reassurance, very important part. We should talk to the patient, we should communicate to the patient, we should provide comfort device to the patient and make him reassurance that he'll be recovered and he'll get treated and best treatment he is getting. But very important part, we should not give the false assurance to the patient. Venous thrombosis prophylaxis. Because in the critical patient care, patient will be remain for the longer time. So he required venous thrombosis prophylaxis. Otherwise, he will develop the different thrombosis. So always we should change the position. Very frequently we have to change the position of the client. Ambulation is required. So what kind of things what we can do that at the bedside we should prepare a clock, and we have to decide at 12 o'clock patient will be in the prone position, 2 o'clock in the semi-fabulous or we can say lateral position, semi-lateral. So we have to make some clock and we have to, we have to plan for the positioning. So we have to see what time the patient should what in which position. So this will become practice and how we can, provide such kind of positioning, which will also help in the preventing this venous thrombosis and also help in prevention of the diabetic, this is type 2 diabetes ulcer or the pressure sore. Infection control, very important part because the patient is coming in the hospital for his treatment, and if we are giving you as a token of love infection control to the patient, that's not a good phenomenon. Because many of the patients we know that we are giving some of the ventilator infection, we are giving surgical site infection, we are giving the catheter-induced or associated infection. So we have always, we have to prevent that. We have to use all the aseptic techniques. We should use the gloves, we should use mask, cap, face shield, and gowns. All the procedures should be done in the aseptic technique. So we can prevent this control infection, and especially in the critical care unit, they have to take care of it. That's why especially the microbiology team, what they are doing the sudden inspection in the critical care unit. They are taking the sample from the patient, staff nurse hand. They are taking from the bedside. They are taking the culture and they see that whether they are maintaining this component or not, whether they are having infection in their hand, which are they given to the patient. So we have to control the infection. Skin care, general hygiene, and mouth care. This is very basic hygienic care for the patient. Those who are bedridden, they require special skin care. They cannot do anything by themselves. We have to provide positioning. We have to prevent, with back care. We have to give them the all the skin care, general hygiene, like how we are giving the mouth care, we are giving the eye care. The patient comatose cannot have movement of the eyes, then maybe keratitis will be there, and this further lead to the blindness of the patient. This is very simple phenomena. If we provide the eye care, then we can prevent that. So we have to provide complete hygiene to the patient. Fluid, electrolyte, and glucose balance, because the dietary management is very important. Patient cannot take by himself. So there is an imbalance of the electrolyte will be there, and again this will lead for the further metabolic problem. So we have to provide complete fluid and electrolyte and glucose balance to the client. Bladder care, because we are doing the catheterization, then time to time we have to do the dressing, we have to disconnect it, we have to see any pus formation, any blood charges will be there. Complete monitoring should be there. Pain management. In terms of the pain management, we always go with the pharmacology and non-pharmacological management. Both we have to do from nursing aspect, non-pharmacological management as well as pharmacological management, and we have to reduce the pain of the client. Dressing and wound care. This will help to decrease or reduce the days in the clinical care or missing critical, because patient will like coming from the OT area, and if we are not able to control their wound and is expanding in the nature, like having the more bacterial infection, more growth of the bacteria, then patient will remain longer for the patient. And sometimes if there is a laparotomy surgery has done and the patient had an infection, then they have to reopen again. So dressing and wound care is very important. Communication with relative, that's very important part. We always talk about the psychological support, but in what term we are giving psychological support? We should have proper mentoring, proper psychological support, proper information to the client and relative. So this information is very important, and this communication will make sure that the things, whatever is going on, this is best for them and best for the patient. Record and report. This is one of the important part, because sometimes the incidents may happen which are against the policy, but it has to be reported. And this reporting system will increase the quality of care and standard of care. Once we have talked about the challenges, how to overcome with the challenges, what kind of the management, what we have to do, but how this will be implemented is very important. And if this implemented, then how we can overcome with that. So optimizing early ICU mobilization and rehabilitation is very important, because one patient got admitted in the critical care unit and there is no early mobilization will be there, then there is no quality of care. So early mobilization and rehabilitation process is very important part. So create a multidisciplinary team with the champions, with those who are very expert. We have to always take advice from them. We have to take, the rounds of that, and we have to take all the care in component of that. Use a structured quality improvement process, very important. Quality improvement, always we are talking about the quality improvement project, quality improvement. How? If I'm working in the ICU, I should know what kind of quality improvement I have to do. I have to take care of the bundles which are very prone in ICU. So that quality improvement, it should be in terms of the infection prevention, in terms of the quality of procedure, in terms of the output of that procedures. So that has to be maintained. Identify barriers and implement facilitators. Because barrier will be there. Until and unless we get barrier, we will not have one idea. We cannot implement it. So we should identify the barrier where we are getting problem, where we are lacuna, and what kind of implementation are required. Promote multi-professional communication. As I told, this is the comprehensive care. Multiple component will be used. So that has to be done. Understand patient preference, because we have to talk to the patient. We have to ask them what kind of problem they are facing. We have to understand their priorities. And once we'll come talk to the patient, we'll come to know what patient exactly facing and what we have to do that. Adopt safety criteria. As I told you, have to create the safety culture in the critical care unit for the patient also, for healthcare worker also. Because sometimes they have burnout syndrome to the staffing because of the long duties. So we have to look after to them also. We have to mentor policy of staffing also. Implement care bundles for pain, sedation, delirium, and sleep. We have to see for that. All kind of the care are the points we have to keep in mind whenever you are looking for the critical care unit. Obtain any necessary assistive equipments. All the equipments which has to be required should be kept and ready for the use. Evaluate optimal timing, type, and dose of intervention. We always, whatever the intervention we are doing, we always have to evaluate that, whether that has impact or not, what the things can be added, what deletion can be done, how we can improve day by day our practices, and regularly evaluate outcome and performance. Because no one is evaluating your quality, then you cannot work, you cannot improve, you cannot change. So always whatever you are doing, that should be an evaluation will be there. That evaluation will be there on the morbidity, mortality, readmission, quality of care, infection rate, and many more components has to be added. Then only you can say if whatever quality of care you are providing to the ICU or the patients, they are improving and our quality of care is good. If I say my ICU is good, I do not giving infection to the patient. But if I go through certain cultural tests, like if I'm taking the tubings of the catheter, I'll taking the hand hygiene culture, and if there is infection rate will be there, then the infection rate is very high. So how we have to evaluate? We have to create such kind of the compliance which will give you the result, and you can say like, yeah, this ICU or the critical care is providing the best of the best care, and patient are getting discharged on the time, and all the patient are getting equal chance to get admission, and this ICU or critical care unit is providing the best care. So that's why the ICU mobilization and rehabilitation is very, very, very important part. So I think this is all about my talk of today's, what kind of the challenges we have, how we can overcome with these, what the basic management we have to do, and what the management in terms of the patient we have to look after in the critical care unit. Thank you very much for listening patiently. If you have any doubt, I'm happy to take it. Thank you.
Thank you, sir. For such an informative session, you have covered all the information we require as minimum to maximum. If anyone wants to ask any question, can ask or write in the chat box. So now we are moving towards the next expert talk. So here we are going to expand our knowledge on the topic of role and scope of critical care nursing by speaker Mr. Divya Jain, Assistant Professor, Manikaka Topawala Institute of Nursing, Charusat. Before Sir comment his expert talk, we will have some glimpse of his career in nursing profession. Sir has done his graduation from Bharatiya Vidyapith University, Pune, and post-graduation in Medical Surgical Nursing from Symbiosis College of Nursing, Pune. Sir is ACLS and BLS qualified, GFATM trainer, NRPF trainer. Sir is member of TNAI, NRSI, and the Critical Care Nursing Society. Sir has done many publications. Sir is an examiner in the various universities and institutes. Now, I request Sir for the expert talk.
Thank you, Sachi ma'am, for such a wonderful introduction. I hope I am audible and my share screen is visible.
Yes, sir.
Okay. In last 1 hour, we have seen many things comes under critical care nursing as a part of management. Now we'll be more focusing to see role and scope of critical care nursing. And what I feel is rather than going to the bookish language like what we studied earlier in our bachelor and masters about role of a nurse, then the scope of nursing, will be sharing few personal experience as well. If you see the management part and the role of a nurse, it goes very parallel. Then if we little bit talk about the history of this critical care nursing, so previously what supposed to happen is there were no specialization. If we see the history of our nursing profession, and then the advancement were there, and then we have started with some specialization. So previously all the patients who are from different cases from different system diseases, they kept all together in single ward or same ward, and the care is also according to that. But then advancement was there, and now we can see that there is a specific unit for each and every system. So if you visit some good multi-speciality hospital today, you will find that there are several ICUs nowadays. So there is a separate floor for ICUs, starting from respiratory ICU, cardiac ICU, neuro ICU, critical care ICU, ICCU, and many more. And this advancement increases our role as well as our scope being as a critical care nurse. So today we are more focusing to see this. Before starting the session, we will little bit discuss about the role and need, actually why there is a need of a critical care nursing in current scenario. So if you see the diseases which are coming out recently, we have seen this pandemic, comorbidities with this COVID-19 and many other things we have seen in recent 2-3 years. Even if you see motor vehicle or road traffic accident in India nowadays increasing day by day. Polytrauma cases which we are seeing in casualties are much more nowadays as compared to earlier. So seeing such patients who are coming with heart attack, MI, angina, stroke, shock, motor vehicle accidents, multiple injuries, multiple or organ failure, you can say. Looking at such patients require additional knowledge. It requires skill to take care of such patients. So we'll be specifically see what are our roles and scope in critical care nursing. If we talk about critical care nursing, it's a specialty within the field of nursing. This specialty is performed on the basis of advanced knowledge, skills, and general competencies within the area of patient's treatment, its education, professional development, interdisciplinary collaboration, and organization. we'll be first discussing about the role of a critical care nurse. So critical care nursing is evidence-based and embraces health promotion and disease prevention, illness management and rehabilitation, as well as palliative measures also. So starting from prevention and promotion till the end stage of life, we are actually taking care of the patient. Now, if we talk about the patients which comes to us in a critical care unit are not a common patient where we just only take vitals and we just only give medicine and the work is done. It is not like that. We require much more than this. Now what we require actually and how to fulfill our role being as a nurse. See, critical care nursing is very narrow subject because once we complete with medical surgical nursing, we have various systems in it. And out of that, there is a super specialty called as critical care nursing. So there are nowadays separate super specialties available. And for SAM, there is a different courses are also available. There are different roles, responsibilities are there to fulfill in critical care scenario. So being as a nurse, before going to role, what is our responsibility is to have that, to acquire that knowledge and skill. I request everyone to mute your microphone, please. So first role, if we see in an ICU scenario, is patients monitoring and documentation, where most of you have seen the monitors where it shows heart rhythm, heart rate, oxygen saturation, respiratory rate, exhaled carbon dioxide concentration, partial pressure of different things, non-invasive blood pressure, arterial blood pressure, central venous pressure, temperature. So nowadays we have advancement in technology so that we can easily see all these on a single monitor. But again, understanding all this, for example, first point in it is heart rhythm. So for reading a heart rhythm require little bit of knowledge as well as skill. So for example, that is a part of scope also. Now I'll give you an example is if you are standing in front of a patient who is admitted with the complaints of palpitation and suddenly patient becomes bad and the monitor is showing ventricular tachycardia. So first of all, you should understand how to read ventricular tachycardia. Once you understand that, you should be able to do the things afterwards, like you have to follow algorithm for ventricular tachycardia. So you should be understand that yes, this is a case of cardiac arrest and I have to done many things with that. For example, preparing a IV access with drug called as epinephrine or adrenaline. So how all these things will come when your basics are very clear. So that is our role actually. By seeing the ECG rhythms, we'll need to identify what is the condition of the patient. Same for heart rate. So there is a separate algorithm available for heart rate. If we are actually discussing very specific role in ICU only. So for example, heart rate. So if it goes below 60, definitely it is bradycardia. So there is a separate treatment algorithm which we need to follow for bradycardia cases. We need to get done with IV access with a drug called as atropine and many other causes, reversible causes we need to identify in such conditions. Same for oxygen, same for respiratory rate and other parameters also. So these all are our role to see it first, to identify whether it comes under a normal range or not. If it is not normal, what next we supposed to do? So that is first role of a nurse in critical care scenario. Effective use and interpret bedside monitor that we little bit discussed about. So for example, there is one system nowadays it is working well in most of the hospital called as clinical information system. So all the data available in a single system, in a single PC, in a single computer. So you can see starting from personal biodata till the treatment and discharge. So everything you will get in a single computer. So it may include intervention, daily vitals and everything. So you should know, being as a nurse, how to take care of such advancement. For example, you should know how to operate this clinical information system. Patient physiological observations are there. Care or interventions delivered are always there as in history of the patient, as well as medication plans nowadays are also there in the system. So everything is there in the system. Now our role is we need to identify what is normal, what is abnormal. We need to interpret the data which patients are showing every time in ICU. Critical thinking, interpretation and decision making. I'll give you the example of critical thinking also. ICU nurses must be able to draw ABG blood and interpret the report correctly. Now, looking at this topic itself, ABG blood or ABG analysis, which we say, so we have specially 5 components which we see in ABG. So we all should know what are those 5 components, how to read it, what is metabolic, what is respiratory, acidosis, alkalosis. So by reading this, we'll come to know, by interpreting this, we'll come to know to a conclusion. We will come to a conclusion, we will be able to think of the treatment part. Knowledge about GCS, that is Glasgow Coma Scale. So many patients, those who are admitted in ICUs, require this assessment called as Glasgow Coma Scale. Now you need to update yourself with such things. There is a change in Glasgow Coma Scale nowadays. So we have added one more point. There is a 15-point scale that is remains same, but additionally we have pupillary reaction score. So which is called as in short PRS, which is of 2 points, 2, 1 and 0. So that is the additional thing. So according to our INC syllabus also, see, our syllabus is not updating every year or every 6 months. So looking towards that, and if we compare our syllabus with current situation in ICU, there is more advancement in ICU. So there is a gap actually. There is a gap between our syllabus, though it is updating periodically, but still if we see, there is a gap. And new advancement are not a part of our syllabus now. So who will teach us and how we will learn? So we will learn by taking additional courses, especially in critical care nursing, so that I will talk later on. Life-saving situations using nursing standards and protocols. So many patients, I think most of the patients or all the patients who are admitted in ICU are on a risk of death or a risk of going into a case called a shock, or maybe the risk of heart attack maybe, or massive heart attack. So such patients are always on risk. Life-saving situations are when the patient is not showing any pulse, when the patient is not showing breathing. Your role starts over there, that you need to identify a patient is not showing pulse as well as breathing. What next you're supposed to do? So our priority, our role in that situation is we should start CPR immediately. And as soon as the defib is available, we should deliver the shock, defibrillation shock. So that is our role actually. Endotracheal intubation, assisting in endotracheal intubation, very important. And defibrillation or cardioversion. So that is actually our role. We should know what is defibrillation, what is the difference between defibrillation and cardioversion. Very important, ECG interpretation. Most of the patients in critical care units are showing dysarrhythmias. And how we will come to know that the patient is showing dysarrhythmias? Our role is we need to interpret it. How we will interpret it? Whether even if we have good knowledge, we require experience to interpret it. So first of all, we need to gain that knowledge, that skill. Specifically, if I talk about ECG, so ECG, if I talk about CPR, so that additional part we must gain through various courses that I will show you. Critical thinking again, or you can say you can merge this with uh, decision making. So for example, again, our role is to identify the situation. Now, for example, we have various treatments available. For example, cardiac arrest. So what we can do, we can identify the rhythm and we can start giving CPR and defibrillation, and we can give IV access and we can give some drugs. Same patient is showing after 2 minutes, same patient is showing tachycardia, maybe SVT, supraventricular tachycardia. So you need to change your complete plan from cardiac arrest to supraventricular tachycardia. Now the drugs will change. Now the complete treatment part will change. So that critical thinking you should have, that decision making, quick decision making you should have. Patient will not wait for us. That is the role of a nurse in critical, that the patient will not wait for us to think more. Many patients die within few seconds to minutes. Why? Because they are not getting CPR on time. They are not being intubated on time. They are not getting resuscitation on time, resulting there is more mortality in critical care units. Who is responsible? Definitely the staff, the team within the ICU is responsible. So this critical thinking is again directly linked with our knowledge and skill. So as I said, you need to shift your role by looking at the ECG, by looking at the patient's condition and act accordingly. And that is also very quick. Psychosocial care. There are chances of physical and psychosocial stressors immediately on admission to a critical care setting. And this is the role where we started our role in giving pain reliever. For example, for physical pain, we can give pain reliever. So that is our role. Unfamiliar environment. So it is for every patient that as the patient is feeling unfamiliar environment, there is a equipment and treatments, sensory disturbances, isolation from family, loss of autonomy from the patient side, impaired communication. Many of the patients are on tracheostomy. They cannot able to speak anything. They cannot communicate with you. But being as a nurse, what is your role? Say for tracheostomy patient, many patients are awake. Not all patients are semi-conscious or unconscious. So lip reading, you should know what patient is actually telling to you. So that is a part of your communication. So that is one very big major role of a nurse, of communicating with other staff, patient self and the family members. Fear for their life. Patients, those who are admitted in ICU, somewhat they have fear of their life, fear of dying, fear of death, and your effective communication require over there. Your sympathy require over there. Many patients we will get in ICU which are dealing with their end of life. So end of life care also, we should have that much of skill that we can deliver that resuscitation part. Even at the end of life, we should have the skill, and that is our role of breaking a bad news in front of relatives, in front of family members. Critical care environment, if we talk about, critical care nurses or ICU nurses must be physically, mentally and emotionally strong. Very important point, to work with seriously ill patients and their loved ones. Critical care nurses are responsible for managing medication doses, uh, anesthesia, ventilator support for patients like those who are unstable. Even we have a major role as a code blue team member. In various hospitals, we do have active code blue team, where we have to activate a code blue team, and the code blue team is consists of physician and nurses and technicians who actually take care of patients, those who are not breathing and not showing any response, no pulse, and that is a sign of actually cardiac arrest. So we need to activate it. So that is our role. If we see this image is actually showing us so many things together. A patient is there on a bed, and if you see, there are multiple attachments with the patient. It is showing about the condition of the patient. The case start from it is, see, if you are a critical care nurse, it doesn't mean that we are only taking care of resuscitation part. We are only taking care of trauma patients or wound care. It is not like that. Basic cares are also required in ICU. For example, changing the position. That is our role, to prevent bed sore. Giving RT tube feeding. That is our role. Uh, Taking care of skin of the patient. That is the important part in ICU for all the patients. So maintaining skin integrity is important. So if you see this image, we can understand there is a technological advancement. There are many attachments with the patient. And being as a nurse, our role is we first well equipped with our knowledge and skill with all this technology, new advancement. So one side, if you see, there is a monitor. There is one side, if you see, the patient is on ventilator. If you see, there are more attachments, IV sets, IV lines are there. Infusion pumps, different infusion pumps are there. With infusion pumps, we should also understand the cardiac or emergency drugs. So this image is actually showing many role of a critical care nurse, starting from personal hygiene. And if you see the patient, starting from the bed of the patient and surrounding, the patient is surrounded by technology. Treatment and rehabilitation role. Uses advanced medical technology for safely and appropriately. The nurse should also work with an interdisciplinary team and appropriate documentation. See, we are dealing with critically ill patients. Documentation is equally important. So documentation, why it is important in critical? Just to prevent malpractices and negligence. Malpractices or negligence may include a very common condition, means giving a double dose of a drug, any emergency drug which is given 2 times. So the patient, definitely the patient will suffer. Teamwork, again, this is very important point, that there is the nurse actually work in a team in ICU. So for giving a CPR also, a nurse alone cannot give CPR. After giving 2 to 3 CPR cycle, he or she may tired and will not be giving next cycle very effective, resulting the patient will suffer. Maybe the patient will die because you have not given effective CPR. Though you are giving the CPR, but it was not very effective. You have not used push hard and push fast. So it is a teamwork. We need to work with physician. We need to work with other nurses also in the ICU. Even if you are resuscitating a patient, you require group of people over there. Even if you are giving a CPR, you require group of people. Even if you are receiving a patient in casualty, in trauma, which the patient is of polytrauma patient, for example, where the patient is having multiple fractures, multiple injuries, patient is bleeding from here and there. there is a chance of shock, patient is showing a sign of shock. In such condition, you alone being as a critical care nurse cannot do anything, because such patients require immediate actions by multiple team members. So one side you may start with IV access, one side someone else will stop the bleeding, one side the patient, the person, the staff is uh, handling the head for preventing cervical injury or stabilizing the head. Other one side is again stopping the bleeding. So all together, this is a teamwork. That is very important as a role of a nurse, that nurse should work in a team in ICU. Comfort and palliative measures. Performs procedures to relieve symptoms. Participates in decision-making processes concerning the limitation of life-prolonging treatment, and shares responsibility to facilitate a peaceful death. Life-prolonging treatment and their limitations may come with few topics like do not resuscitate or euthanasia maybe. Though euthanasia is not legal in India, DNR is, again, we can take the proper consent. That is our role, to take the proper consent of the patient and relative, looking at all the criteria. So our role comes in that condition also. For example, organ donation also at the end of the life. So there is a separate process of giving organ donation, the donor and many other criteria are there. So we are active member in that decision making. Palliative measures is, there is a myth that whenever we heard palliative measures, we always think that that is at the end of the life. So it is not like that actually. Palliative measures can be start as soon as when the patient is diagnosed with conditions, maybe conditions like AIDS, HIV, or maybe oncological conditions, cancers. Teaching, professional development, and research. So our role of a nurse, the role of a critical care nurse is not limited to the clinical side. Nowadays, it is more of teaching, professional development, and in research. So now many critical care nurses are, so that is a part of scope also, that many critical care nurses are working in institutes, in colleges, in different settings, where they are actually actively teaching about critical care nursing. They are using evidence-based approaches. Here, as the research word comes, I would like to take one more part, that is, there is a huge gap between current researches and actual implementation in clinical settings, because we do not have, the nurses do not have habit of reading the current articles, researches, what are going on in researches, specifically in our profession. So we do not have such habit of reading it, resulting there is a huge gap. One side there are researches which are very important, their results are very important, which we can actually implement in our clinical setting. But at one side, what we are doing is we are just following the same thing again and again and again. Why? Because we do not read it, and there is no such policies or protocols in hospital which I have seen till now, which I haven't seen, that there is a compulsory reading of a journal or an article on a routine basis. So actually researches are for that only. Researches are to improve our nursing care, especially our critical nursing care, to save the life of a patient. But we are not able to use it because there is a huge gap. So our role nowadays and in future also, the research advancement are more and more and more. So we need to make the habit of reading latest articles from very good journals. Then only we can shorten this gap between this clinical side as well as the academic side. Collaborates with teaching institutes with regards to provision of clinical practice. So that I have already discussed. The nurse should understand about ethical awareness. That is our role, to understand ethical awareness. So whatever I am discussing as a part of role, that all can comes under what we till now studied in nursing, like educator, planner, good advocate, leader, researcher. So these are the roles actually. So I am actually giving you more specific role, particularly in critical care nursing. So as I said, I have highlighted two words here. One is research activity, which is the actually future of our profession, and technological innovation. Again, technological innovation is on a daily basis. We are getting very new things every day in a part of teaching, in a part of actual direct care to the patient, and we should understand that. We should gain that knowledge and skill. These are some of the common role of a nurse which he or she should take care of, like support and respect for the patient's autonomy, helping the patients to obtain the necessary care, continuous monitoring. That is very important, to monitor the patient continuously. Though many of the patients are on continuous monitor in ICU, we need to monitor them. Efficient individualized care. Definitely all patients coming to a single ICU are not same, starting from their gender, starting from their age. So every patient is individual. Every patient is required a separate care. So we need, being as a nurse, we need to identify what are the needs of the patient in critical care nursing. Counseling and information to family. See, family members are equally important in critical care nursing. Though we heard nowadays that many patients are become literate now, many patients or relatives know about their cases, their condition, their prognosis, their deterioration, etc. But if you see actually in the clinical side, many patients, many family members have deficiency in their knowledge, resulting they do not know what is going on inside the ICU, and resulting that they increases with their anxiety, fear. Counseling is required in such conditions. Counseling include one very important part called as communication. So your effective communication is a very good part of counseling. So counseling is not only for patient but family members also. Application of policy and procedure. So now every hospital have a different policy to work with and to follow, and then procedures which we have to follow. Record all the activities. Generally, as a nurse, we have to record all the activities, whatever you are doing, even if it is so small. Maintain infection control principles. This is one of the biggest challenge nowadays in any hospital, in any critical care situation, that nosocomial infections are high and high. Though we are giving many training of aseptic technique, though the nurses are well equipped with this knowledge, still there is a high chances of nosocomial infection in such patients, those who are admitted in critical care. So our role is to identify it, to prevent it, to prevent this nosocomial infection. Keep update with advanced information. So how we will keep this on updation? When we will read more and more, when we will go in service or continuing education, then only it is possible to update ourselves with advanced technology or information. Then resuscitation, intubation, CPR, these are the critical part which we perform in any ICUs or maybe somewhat in trauma centers, casualty or emergency room, where the patient brought with multiple injuries, polytraumas, as I said earlier. So these are in general role of a critical care nurse. Let's talk about the scope of a critical care nurse. So the scope of critical care nursing practice is described as a dynamic process with major three components. Number one, of course, a critically ill patient. Number two, the critical care nurse, and the environment where these both are working. They both are there. So the environment where critical care nursing is actually practiced, so that is our ICUs. Scope of critical care nursing is to provide immediate action to treat the patient. So this is the scope specifically in terms of care. For crisis interventions, when we heard about crisis intervention, disasters also comes in it. So when there is a mass casualty, when there is multiple patients coming towards the casualty, we being as a critical care nurse has very wide scope in such situation to take care of patient, to segregate the patient, to give intervention in such crisis situation. To treat emergency condition, if you see, again I'm repeating that if you stand for 1 or 2 days and just try to identify which patients are coming on a daily basis, so we'll find nowadays bites patient, bites of maybe dog bite, snake bite, shock patient, patient with shock, palpitation patient where the patient is showing the sign of heart attack or MI, myocardial infarction, or then road traffic accident. Everywhere in every casualty you will find many cases on daily basis on road traffic accident or motor vehicle accident, and they come with sometimes minor injuries or sometimes very major injuries called as polytraumas, where they are showing the fracture of femur maybe, which is very dangerous, where the patient may go in shock because of hypovolemia, so that is hypovolemic shock. So we all should understand that. To treat wide variety of illness starting from sore throat to heart attack. So yes, that is again our scope, that we are facing patients with wide variety of illness. So as I have given the example of heart attack, maybe patients may come with some little conditions. They feel that they are not very serious, but again, being as a critical care nurse, inspection, palpation, percussion, and observation is must. That is our scope. That is our scope of practice. So that is very specific scope. Now, scope in terms of career in our nursing profession, being as a critical care nurse. So with the expansion of healthcare industry and increasing awareness of people, medical courses are the hot seats among various courses. Individuals after completing this course will have a plethora of job opportunities to explore. While most of them work in intensive care units, either in private or government hospitals, some make a career as an educator in different nursing colleges or training institutes. The present ratio of nurse patient is a humiliating. So that is humiliating one, but with this pandemic, the importance of healthcare professionals is out in the open, very important part. If we see our role in current or past 3 years, if you see with this pandemic, people are knowing us well now. Our profession is quite open now for everyone. So a lay person who was not able to knowing what is this profession and what is the role of a nurse, now they are well aware of our profession, and because of that, there is an advantage that we are in high demand now. So this opportunity for qualified critical care nurses are vast, and are available abroad as well. So if we see this scenario in Gujarat also, so out of a batch of 60 students, I think so 30 to 35 students are going to abroad just to see their career over there. And they think that they have good career over there because we have high demand in abroad for skilled critical care nurses. But again, being as a critical care nurse, we need to be very smart because as the demands are high, the competition is also high. So if you are very skillful and knowledgeable with advanced courses, you have full chances of getting jobs in India as well as outside the India and abroad with a good position, with good designation over there, and with good salary also. If we see specific scope in research, so there are new innovations, as I already discussed in the role also, solutions to various problems. So once we start research in clinical side, though the researchers are conducting at clinical side, but it is very little. We need to enhance it just to give more and more evidence to our profession and more new advancement to our profession. Education, so we have wide variety of scope in education side like nurse educator. Nowadays, we have advanced skill lab everywhere, like how we have in our college, where we require a specific faculty who can actually take care of all the advanced dummy, who can actually show effectively to the students that how to perform a particular procedure to a advanced dummy in that particular skill lab. So that is now the advancement in education. Same, we have some courses available which one I have mentioned like SWAYAM and NPTEL. So they are actually run by the government of India. Very nice courses are available for nurses as well as for physicians also, for paramedicals also in SWAYAM and NPTEL. So these are certified courses. You can actually pay the fee whatever is there from different courses, and you can actually get certified with various courses. Very small courses are available, and which is very nice. So these are the scope in education side. Administration side also, at various platform we can work as a leader. As a academic side also we can work as a leader. Hospital side also. Now, as I said that we have a variety of ICUs in multi-specialty hospitals nowadays. So floor wise also we can make the leadership. So there is the scope of us in administration. Clinical side, private practice, critical care nurse practitioner nowadays, like for example, if I give my own example, in our college we have started with geriatric nursing clinic. So we are running geriatric nursing clinic. So that is one type of scope for a nurse. For example, daycare center also. So many other things are there. For example, a hypertension clinic or critical care nurse clinic. Some trauma centers which are only running trauma centers, which are not running with general ward or OT or something like that, but they are only take care of patients who are coming with trauma. So such trauma centers are also invites such skillful nurses. So we have variety of scope in clinical side also. These are the few courses I have listed down, which is a part of either in-service or continuing education. These are the actually more of in-service education. If you are a faculty, definitely you can go through this. And I recommend these courses, those who see their career in critical care nursing and those who are interested in can go with such courses. They are very specific courses for some duration, and you will get the certificate, and the knowledge and skill you will get out of these courses will help you in your role, your responsibility, and it will improve your scope as a nurse in future. So like CPR, BLS, like cardiopulmonary resuscitation course, basic life support course, ACLS with advanced cardiac life support, advanced trauma life support, same for pediatric, so that is PALS, pediatric advanced life support, NRP, neonatal resuscitation program, specific courses for ECG, for dysarrhythmia interpretation, ventilator and tracheostomy training skill. So I'm certified with CPR, BLS, ACLS, NRP, ECG. So ECG, ECG, ACLS, and BLS covers in advanced cardiac life support only. Ventilator and tracheostomy training and skill. So that is again a separate. So all these courses you can undergo. You can get good knowledge, good amount of skill, and this is actually according to AHA. They are given by American Heart Association. So this is my recommendation. So advantages of becoming a critical care nurse. So you can take this as a role or maybe scope. The reward of having a part in a critically ill or injured patient's recovery. So you will get full satisfaction after the recovery of a patient. Because we know that the patient's life is in our hand, especially in critical care. We are providing them the holistic care, we are taking care of vitals. So we have that sense of fulfillment. So that is one type of advantage in critical care nursing. Get to work with various professionals and work as a part of a team. As I said earlier, here you will get a chance to work with a team, within the team. So for a general ward, what is happening, you are getting many patients at a time. You will not be able to give this specific care to each patient. But here, the ratio is maintained like 1:1 or maybe 1:2, and you can actually focus more on such patients, critically ill patients. So that is again a sense of fulfillment. Critical care nurses only provide care to a few patients at a time, as I said. Opportunity to work with state-of-art medical technology. So we get the opportunity, being as a critical care nurse, to work with advanced medical technology, advanced catheters, maybe many things like maybe ventilators, newly advanced ventilators. So with a team, like we exposed to so many things, for example, pathologies, different therapies, maybe infection control team. So working with all of this, all of them will give you a different kind of experience. And again, I'm telling, this will give you a sense of fulfillment. So these are few advantages of becoming a critical care nurse. So my recommendation to improve our role is one which I have done this course 3-4 years back. We actually get this license for next 2 years once you complete this course, and then again you have to repeat for the examination, because these ACLS courses they always add or they always modify the things. And believe me, after this particular course, I have learned many things in terms of starting from BLS, CPR, more of medication, pharmacological, resuscitation, overall resuscitation, and how to treat a patient. So there are actually 4 algorithms in this. I'll just take 5 to 10 more minutes on this. So for example, we have cardiac arrest algorithm, we have bradycardia, we have tachycardia algorithm. And many patients in critical care nursing will come and will show you all these symptoms, all these conditions, whether it is cardiac arrest, whether it is bradycardia, whether it is tachycardia, or maybe if you treat the patient, so the patient may go in a state which is called as ROSC, return of spontaneous circulation. So for this also, once you recover the patient, so there is a separate algorithm after recovery what you're supposed to do. So such things are happening in such courses, which is very effective. This is the 3 days course. Once you complete it, you have to give the exam. The ratio of passing is also little less. So you have to work hard for this exam. You have to learn so many things in it. But once you get the certificate, definitely you will learn a lot of things which you have not studied at your bachelor as well as your master level. So that is my recommendation. Again, recently we have done a course on pallium or palliative nursing, and where we have seen that even critical care nurses have scope in palliative nursing, in rehabilitation nursing. So that is again a course for recommendation, like foundation courses by Pallium India, palliative nursing. So that is also you can go under. ACLS courses, uh, if I talk about this region, so Shri Krishna Hospital Karamsad is offering this course. So you may contact over there for advanced cardiac life support course. So as a critical care nurse, we have the opportunity to heal the heart, mind, soul and body of our patient, their families and ourselves. Thank you with this quote. If you have any doubt, you please ask.
Thank you very much, sir, for sharing deep knowledge about the scope and role of nurses in the critical care area. If anyone wants to ask any question, can ask. Once again, thank you, sir. Now, to impart befitting conclusion, I now request Ms. Komal Chauhan, MSc Nursing Tutor, DPCN, to propose the vote of thanks.
To all respected dignitaries and the delegates. It is my privilege to present the vote of thanks of this e-conference on advancement in critical care nursing organized by IQAC and Medical Surgical Nursing Department. First, I am heartily thankful to the management of Mahagujarat Medical Society for facilitating conference with constant support. I would like to convey my sincere gratitude to Dr. B.S. Salas, sir, Director of Dinsa Patel College of Nursing. I am indeed grateful to you, sir, for your continuous guidance and enormous support as a backbone of the conference. Thank you, sir. I would like to express my profound gratitude to the Mr. Nipin Kalal, Assistant Professor, College of Nursing, Assistant Nursing Superintendent, and Transplant Coordinator, All India Institute of Medical Science, Jodhpur. Mr. Divya Jain, Assistant Professor, Manikaka Topawala, Institute of Nursing, Charuset, for sparing time from busy schedule and accepting our invitation to share your knowledge and to be part of the conference. Thank you so much, sir. I like to express our sincere thanks to Principal Professor Virendra Kumar Jain, sir, Organizing Chairman of Conference, for giving logistic coverage in planning and organization of conference. Thank you, sir. I would like to convey my sincere thanks to Mrs. Arpita Vaidya, ma'am, Vice Principal DPCN, for kind guidance and support to make the conference successful. Thank you, ma'am. I am thankful to Ms. Sachi Christian, Organizing Secretary, Assistant Professor, Medical Surgical Nursing Department, for tremendous tireless effort to make this conference successful. Here, I would like to thank all medical surgical nursing department members for their absolute support. I must mention a hearty thanks to all nursing family for excellent response. A big thanks to all delegates. I would also like to thank all our organizing committee members, non-teaching staff, students. Without your participation and great support, this conference cannot achieve a high standard of success. My special thanks to technical committee for making this conference on virtual mode. I thank everyone whose contribution has made this conference a successful one. Thank you all.
Thank you, ma'am. Here, we are ending with this conference. Once again, thank you all the delegates for the participation. Thank you.